Okay. I'd like to now, Dr Alison Black is, unfortunately, she's in Aberdeenshire just now, so braving Storm Babette, but is very kindly streaming in to deliver her presentation. Dr Black leads the Fracture Liaison Service in NHS Grampian and will talk us through the individual experience of attending fracture liaison services and the positive impacts these have on people's lives. Okay, so I'll hand over to you now, Alison.
Thank you very much. Hopefully you can hear me. Can you indicate if you can or not?
It seems quite clear. Can everybody put up their hand if they can hear, right, especially at the back? Yeah, everybody can hear you.
Thank you very much. I'm very sorry I can't be here today, but the road's closed just north of Dundee, so there's absolutely no way for me to get to Edinburgh, so I'm very sorry about that. My name's Alison Black and I'm a rheumatologist from Aberdeen, and I lead the osteoporosis services in Grampian, and I cover Aberdeen, Aberdeenshire, Moray, Shetland and Orkney. And I'm going to talk today partly as my role as chair of the Bone Interest Group of Scotland as well. So SIGN is the Scottish Guideline Network Group, which gives evidence-based guidelines to enhance practice and for us all to follow in our medical practice in Scotland. And in osteoporosis care, we have SIGN 142. And SIGN 142 was published in 2015 and then updated in 2021. And I was one of the authors of SIGN 142. But one of the things it firmly stated was that patients over the age of 50 who've experienced a fragility fracture should be managed within a formal integrated system of care that incorporates a fracture liaison service. As we all know, a fracture due to minimal trauma, which is an impact equivalent to a fall from sitting or standing height or less, is the hallmark of osteoporosis. And that's what I've spent my career trying to prevent, and I have many others. And that's why osteoporosis is important. It's all about that prevention of fragility fractures. And I'm sure this has already been said today, but I truthfully can't be said often enough. 1 in 2 postmenopausal women will have an osteoporotic fracture before they die, and 1 in 3 men over the age of 60 will also have an osteoporotic fracture. So this is just not an old lady's problem. A 50-year-old woman has a lifetime risk of 17% of breaking her hip. And perhaps most importantly of all, for this particular talk, you're twice as likely to have a further fracture after having had one low trauma fracture. And if that original fracture was a spine or hip fracture, you're 5 to 8 times more likely to go on and have another fracture. So we have really good medications now, and even our most basic of medications, the oral bisphosphonates, significantly reduce your risk of fractures, such as that in the spine, in the hip, and in the forearm. And when we move on to using intravenous bisphosphonates, the fracture reductions are even greater. So this slide quote also comes from the SIGN guideline, and it tells us that those who are at risk of osteoporosis in their care and those at risk of fracture or already sustained a fracture, that the care is actually quite complex because we have to identify them, assess them, and possibly treat individuals who may be unaware that they need treatment. And osteoporosis care is also delivered by many different specialties. I'm a rheumatologist, but endocrinologists, geriatricians, chemical pathologists, they all look after osteoporosis. And of course, we all belong to different societies and therefore don't tend to talk to each other as much as we should. So therefore, SIGN advocated that multifaceted systems of care that integrate all aspects of bone health and falls leading to fracture are likely to deliver greater reductions in fracture than the uncoordinated efforts of the past. So when we're talking about systems of care, we can divide the osteoporosis management into primary fracture prevention in those who've never had a fracture before, and secondary fracture prevention in those who've already experienced a low trauma fracture. So when we're talking about primary fracture prevention, this is about recognising individuals who have risk factors for the development of thin bones and therefore fracture in the future. All of those people who are found to have risk factors for osteoporosis should be given general lifestyle advice, smoking, alcohol, exercise, etc., and falls prevention strategies for those who are considered at risk of falls. And then we should apply fracture risk assessment tools. And there's a couple of them that we use commonly, one called FRAX and the other Q-fracture, which I'll talk about a little bit more. And these tell us about those who are actually at risk of fracture and what their percentage risks might be over the next 10 years. And those who are deemed at suitable risks, or high enough risks, if you like, should be sent on for a DEXA scan. Now, that's not to say that those risk assessment tools should be used just once in a patient's life. They should be used many times in the patient's life, perhaps every 5 years, because age is a great determinant of your risk of fracture. So the 50-year-old lady might have risk factors for osteoporosis, and she should be made aware of that, but she might not need investigation at that stage, but she might do 5 years later. So there are lots of medical causes that make you, medical conditions that make you more likely to develop osteoporosis. So, for example, some things that my endocrinology colleagues look after, such as an overactive thyroid gland, an overactive or underactive parathyroid gland, Cushing's, which is where you make too much steroid of your own without taking steroid tablets, where you suffer from amenorrhea, your periods stop, when your pituitary gland isn't working properly, and anyone who has an early menopause. I'm a rheumatologist, so I look after things like rheumatoid arthritis, which is an inflammatory arthritis condition, and that most definitely leads to osteoporosis. An inflammatory back condition, such as ankylosing spondylitis, also does. And the more common polymyalgia rheumatica also leads to osteoporosis. And often these conditions are also treated with steroid therapies, which again increase your risk of osteoporosis. Gastroenterologists look after problems of the gut, and many of those lead to problems with osteoporosis, such as the inflammatory bowel diseases of ulcerative colitis and Crohn's disease, liver diseases such as primary biliary cirrhosis, chronic active hepatitis, and the viral cirrhoses. And then anything that causes you to malabsorb your food, where you don't get benefit of your dietary intake, such as celiac disease, chronic pancreatitis, etc. And then there's the medications, and I know Professor McCulloch had some questions earlier about medications, and medications do reduce your bone mass. The really bad one is corticosteroid medications, prednisolone, proton pump inhibitors, omeprazole, lansoprazole, which are anti-acid medications, very commonly used. They do reduce your bone mass a little bit, but by themselves, we wouldn't consider they increase your risk of fracture, but in combination with other risk factors might worsen the situation. Enzyme-inducing anti-epileptic medications, so patients with epilepsy who take phenytoin or phenobarbital would be at increased risk of osteoporosis. The now very commonly used drugs, the aromatase inhibitors, which are used in people with breast cancer, and they're anti-estrogen medications, and they can be used for up to 10 years of treatment and can have a significant impact on bone thickness. Gonadotrophin-releasing hormone inhibitors are anti-androgen therapies. They're commonly used in prostate cancer, leading to osteoporosis as well. And they're also now used for endometriosis in younger women, with perhaps an impact in bone mass there too. And then the blood thinning therapy, warfarin, can reduce your bone mass as well. So this is the FRAX algorithm, which is available at the University of Sheffield website, www.shef.ac.uk/FRAX. And this FRAX tool is available to all of us, healthcare professionals and lay people alike. And in this, you can input your own information as long as you're over the age of 40 years. You need to know your height and your weight, and obviously your sex, and some information about yourself, such as have you ever broken a bone before, have you had steroid treatment, did your parent break a hip, etc. And then you can click to give your 10-year estimated risk of having a low trauma fracture. And it's recommended that if that risk of any fracture in the next 10 years is greater than 10%, that you proceed to a bone density scan. Q-fracture is another algorithm tool that can be used. We don't tend to use it so much in hospital care because we can't input bone density data to enhance the assessment, but it is used quite frequently in primary care and can be used by the lay public as well. So if a patient appears to their physician to have a risk of osteoporosis, then a fracture risk assessment should be performed. If that risk is over 10%, then they should be referred for an osteoporosis scan. And if that osteoporosis scan indicates a need for therapy, then that's when therapy can be considered. But as I said before, risks vary greatly with age. So risk factors combined with your age increase your overall risk. So a fracture risk assessment perhaps should be done every 5 years in patients who have risk factors for osteoporosis. So if you need to have a bone density scan done, this is a lunar prodigy scanner. This is what we have in Grampian. There are other manufacturers, but this is one of the very commonly used ones. A DEXA scan, dual energy X-ray absorptiometry, to give it its Sunday name, is a low dose radiation technique with around 10% of a chest X-ray in terms of the radiation exposure. So it's a very safe scan to have. You lie on the table as indicated here, and the arm which moves is the actual scanner. Fortunately, you don't have to take your clothes off to have a DEXA scan, which is very nice, but you do actually have to be able to get onto the scanner. So it's not suitable for people who need to be hoisted to move them. Although truthfully, people who require to be hoisted have low bone mass. You don't need a DEXA scan to inform you of that. The machine will take pictures of the spine first of all, and this is a picture of a lady's spine. We're interested in the lumbar spine, lumbar vertebra 1 to 4, because the rib cage gets in the way above that and the pelvis below that. But that spinal image will represent the whole of the spine and also some other bone in the skeleton which is similar to the spine. So the computer calculates the bone thickness, and then it calculates things called T-scores and Z-scores, which is where it gets slightly complicated. A young person, age of 25, is at their lowest risk of fracture. As we get older, our risk of fracture increases. So a T-score compares you to that 25-year-old individual of the same race, sex and body mass index as yourself, as we recognise that for every standard deviation you fall below the young adult mean, you double your risk of fracture. In 1994, the World Health Organization defined osteoporosis based on bone scanning as to be a T-score less than 2.5 standard deviations below the young adult mean, because that person should be at 5 times a higher risk of fracture than the young person, and that was deemed the cutoff for osteoporosis. And I know that might seem rather arbitrary, but it has been found to be extremely valuable in many studies since 1994. The computer also calculates a Z-score, and the Z-score tells you how your result compares to your peer group. Other individuals of the same race, sex, body mass index and age as you. What we'd all hope is that during life our bone thickness is average for our age or above average for our age, and the Z-score will tell us if we're below average for our age. And if we're below average for our age, there should be an explanation for that. And that might be one of the risk factors we've talked about, but it could be something that you or your healthcare professional are not aware of. And it's under those circumstances, when the Z-score is low, that we recommend that the patient has lots of blood tests to check for other causes of osteoporosis. The other area that's scanned is your hip. It traditionally was your left hip, but now with modern technology, we simply scan both hips. And T-scores and Z-scores are calculated there as well. And the combination of the spinal scan and the hip scan gives enough information to tell us what the bone mass is throughout the whole skeleton and allows us to have a very safe, low radiation technique. The final image that's traditionally performed is a lateral scan of the spine. The patient will roll onto their side and then be scanned from bottom to back of neck. And hopefully you can see in this image that in the middle of the spine there's a vertebral fracture, which the patient didn't know was there. And also in front of the spine, you'll see a sort of a heavily calcified area. And that's the large blood vessel in this patient's abdomen, that's the aorta. And calcification of the aorta will interfere with the scan results. So it's very important that we know of these sorts of issues. So lateral imaging is done in most centres and in most patients. Okay. So I'm not going to talk about treatment in this particular talk, but if you were found to be osteoporosis, then we'll be moving on to treatment at that point. When we're talking about people who've already had a fracture, I'm going to come back to the issue that a further fracture increases your risk of having another fracture. And if it's a vertebral or hip fracture, you're 5 to 8 times more likely to have another fracture. And therefore, we wish to identify those who experienced a low trauma fracture to try and prevent subsequent fractures. And there's lots of evidence to say that you're most likely to have another fracture in the first 48 months after the primary fracture. So therefore there's this window where we need to pick up the fracture, investigate those who have got osteoporosis and get them onto treatment so that that's effective in preventing the next fracture. So we're wanting to identify fractures, investigate for osteoporosis and initiate treatment. And those are the 3 I's of fracture identification. And this is where fracture liaison services come from. The world's first fracture liaison service was in Glasgow in 1999. And this was an excellent piece of work done there at what was the Southern General Hospital in Glasgow and at the Western Infirmary in Glasgow. And there, nurses attended fracture clinics and identified those who had a low trauma fracture. They then referred them for a bone density scan, and the result went to the general practitioner regarding the necessity for treatment if required. This model was studied, and other models have been studied as well, and they reduce the refracture risk, and they also increase life expectancy of those who've had fractures. And of course, in an NHS setting, it's been proven to be cost effective, which is extremely important. So there are lots of models of doing fracture liaison services. The first one is where you identify a patient, investigate it, and then the service that picks up the fracture immediately start the patient on treatment. Model B is the one that's commonly used in the UK, where you identify the patient, investigate, and then the general practitioner initiates the treatment. Models C and D just don't work. That's where you give the patient who's had a fracture information and ask them to contact their doctor, or you give the doctor information and ask them to contact the patient. Those just don't work. You really do have to do this in a systematic fashion in either models A or B. And therefore our SIGN guideline advocates that models A and B should be used in the investigation and management of people who've had a fracture, so that anybody over the age of 50 years with a low trauma fracture should be managed within a formal integrated system of care that incorporates a fracture liaison service. So the standard model for fracture liaison service has never been one that we've used in Grampian, and that's because my patients can go to lots and lots of different fracture services, because there are lots of community hospitals in Grampian, and only half of my population live in Aberdeen itself. The rest of the population live rurally. So it would be impossible for there to be nurses in every fracture clinic to pick up the patients who'd had a low trauma fracture. So we've always identified fractures from x-rays. And in Scotland, we're fortunate that our x-rays go into a national x-ray system, which is called PACS. For example, if I see a patient in Aberdeen, I can look up x-rays that someone had in Dumfries, for example, which is very valuable. So in Grampian, if you have a low trauma fracture, then my radiographers go through the x-ray reports from the previous month and pick up those who've had a fracture, and then list them for a DEXA scan. We notify them that they're going to have a referral for a DEXA scan. We'll let their general practitioner know, and then they'll come in for scanning. But you do wonder how many of these sorts of fractures you fail to pick up, either by a nurse in fracture clinic or by us trolling through x-ray reports. So there's always been a concern that we miss fractures as part of a fracture liaison service. People who have spinal fractures rarely go to a fracture clinic. People often don't know they've had a spinal fracture for some months after it's occurred. They have terrible back pain, and they think, oh, I've hurt my back, and they don't do anything about it until the pain doesn't go away or it becomes unbearable. And then they see their general practitioner and are given pain relief rather than going for an x-ray. So it could take a long time for vertebral fractures to be picked up, and that's very much identified as an issue of the traditional fracture liaison service model. It's essential that for a fracture liaison service to work, you need to have a well-organised core osteoporosis service in your area, or this just really will fall apart. But the model is an international recognised model of care, and it's now used worldwide. And as such, there are now standards for fracture liaison services, and the Royal Osteoporosis Society in the UK has 6 standards of care, as too does the International Osteoporosis Foundation. The IOF have a Capture the Fracture programme, which is extremely successful internationally. I suspect you won't be able to read this, but there are 6 standards of care for the Royal Osteoporosis standards, and they're pretty tough to meet, actually. They say that all people over the age of 50 who've had a fracture, we should be identifying them all, and that within 16 weeks of having the fracture, you should have had an assessment and have recommenced on treatment. They say that the patients who've had the fractures should be given good quality information about the reason why they should be taking treatment, as should the healthcare professional looking after them. They also say that the initial service should make sure the patient has become established on treatment, that they're adhering and complying with that therapy, and that the fracture liaison service continues to educate the population regarding this. So in Scotland, we have universal coverage of fracture liaison services. So wherever you break a bone, in theory, you should have that fracture picked up, and you should be referred to via your fracture liaison service for a bone density scan. But the quality does vary. And that's largely because of the lack of either specialist nurses or of DEXA scanning. DEXA scanning services don't have a great government priority. We don't fall under waiting time guarantees, unlike some other modalities such as MRI or CT. So if your DEXA scanning service sits within an X-ray department, then the X-ray department itself will pull the radiographers away to do MRI and CT scans rather than DEXA scans to meet their targets. So the waiting time for a DEXA scan can be anywhere between 5 weeks and 2 years in Scotland. And of course, The numbers weren't as bad as that pre-COVID, but during COVID, osteoporosis services were closed. And in Grampian, ours were closed between March and August of 2020, and then we just reopened, not exactly with permission, we just reopened. But if your DEXA service sat within X-ray, you weren't able to do that. I was very fortunate that my staff, my radiographers, are dedicated and work within our department. And I think that's one of the things we need to think seriously about when running osteoporosis services, is having dedicated staff, not staff that are shared with other departments. So can we do fracture liaison service better, more effectively, more cost effectively? Well, one of the things that we're trying to do in Grampian via the University of Aberdeen is we have a machine learning project where we can develop algorithms which will read the X-ray reports and pick up whether someone's had a fracture or not. And that reduces man hours, and therefore we can look through more X-rays and hopefully pick up all fractures that have occurred. That sounds really simple, but it's actually proven to be really quite a difficult project, but it is making good progress now, and we hope that that's up live in 2024 in Grampian. As you heard earlier, we're going to be giving some IVs alleged immediately post-hip fracture, and I'll talk a little bit more about that in a minute. There was also a major study done in England a few years ago. It's called the SCOOP study, where they identified people at risk of fracture just simply using FRAC scores, patients over a certain age, and considering that actually whether those people should just be treated or not, rather than going ahead and having a DEXA scan. And that study was a positive study and showed a reduction in future fracture risks amongst those individuals who took treatment. So if you've already had a low trauma fracture and you're over the age of 75 in Grampian, we, rather than arrange a DEXA scan, we write to the general practitioner and ask them to commence the patient on treatment. We are happy to do the scan if the patient isn't happy to proceed without a scan, but that does cause delays in the instigation of treatment, and therefore there will be more fractures occurring if we don't get those scanning times down significantly. So, as we've heard about the Scottish hip fracture audit, hopefully you're all convinced that auditing is a great way of driving up standards. And in England and Wales, there is a National Fracture Liaison Service database, which allows it to be audited against the Royal Osteoporosis Society standards. And funds have been achieved for a scoping programme in Scotland to see whether an audit would be affordable, practical in Scotland. And we're awaiting the results of that scoping programme, and we hope to hear in the first quarter of 2024 whether that is something that will proceed in Scotland. And we very much hope it will, because driving up standards is extremely important, and a variation in services throughout Scotland is inappropriate. We should all have the access to the same care. Even if the care is delivered in a different way, it should always be to the same standard. So, fracture liaison services are a recognised standard of care in patients with a low trauma fracture, advocated by the Royal Osteoporosis Society in the UK and the International Osteoporosis Foundation. It's evidence-based, it's endorsed by our SIGN guidelines and by NICE in England, and there is universal coverage in Scotland, but we do recognise that the quality varies. So I wanted to speak just a little bit about how we actually organise our osteoporosis services in Scotland. So we have an organisation called the Bone Interest Group of Scotland, and I'm the outgoing chair of that organisation. And this is a group of all healthcare professionals in Scotland who look after people with osteoporosis. Endocrinologists, rheumatologists, geriatricians, or chemical pathologists, our specialist nurses, our radiographers, general practitioners. So all those involved in delivering services, bone services in Scotland, are part of the group, and we have representatives from the whole of Scotland. And we meet twice yearly for education, to share good practice, to try and develop Scotland-wide policies to improve care of patients with metabolic bone disease. And of course, the commonest metabolic bone disease is osteoporosis. So in common with everyone in 2020, we met by Teams rather than in person, although our next meeting is in person, which is in November. At that meeting, we're looking at the evidence for giving zoledronic acid immediately post hip fracture to try and prevent further fractures, particularly further hip fractures. And we looked at the evidence at that meeting, and we discussed it as a group, and we developed an algorithm. We sent the algorithm round to all our members for comments, and then came back with a final pathway. And this was quite a complicated process, because the use of zoledronic acid post hip fracture is not a licensed indication of the drug, so we had to get permissions to do so. We had to draw up guidelines for the safety of this, and we had to, of course, have consensus amongst our organisation. But we were able to achieve this and develop this algorithm, which basically says that if you've broken your hip and you're over the age of 50 years, be you male or female, we should be given a loading dose of vitamin D immediately and started on calcium and vitamin D supplements if you're not already on them. If you're already on osteoporosis medications, then this pathway doesn't go any further forward, but the patient should be sent back to their local osteoporosis physician, because you really shouldn't break your hip while you're on treatment. That treatment should be enhanced. If you're not on any treatment, then you go down this algorithm. We ensure that your kidney function allows for the use of zoledronic acid, and then it's given as soon as possible after the hip fracture and before discharge. And then the discharge letter from the hospital then also goes to the local osteoporosis service, so that they can follow on therapy in the years to come, as the traditional treatment with zoledronic acid is an annual infusion for a period of 3 years for maximum benefits. And at the time that we were doing this, work was also going on in England, and as Alistair said previously, we've been able to share good practice throughout the whole of the UK and have a publication in this. And I too was in Oslo a couple of weeks ago, and we were able to present this work in Oslo to the international fracture community, where I would have to say it was really very well received. So there are advantages, of course, of living in a small country of 5.4 million of us, is that organisations overlap. So while I'm a chair of the Bone Interest Group of Scotland, I also was a member of the Hip Fracture Audit Steering Group. And the Hip Fracture Audit wished to enhance their bone health standard, and I presented our algorithm to them, to their national meeting, to the Trauma Orthopaedics in Scotland, and they have adopted this as a standard, and it's now standard number 11 of the Scottish Hip Fracture Audit, which is being rolled out throughout Scotland. And this algorithm looks a little bit like this. It's actually the same as mine, except it's much more colourful and much more professionally done. So thank you very much for listening to me. I'm very sorry I'm not there in person, but I'm happy to answer any questions at all. Thank you very much.
Thank you very much, Alison. That was really interesting. Can you hear me okay on this microphone?
I can, yes.
That's grand. And we have another microphone, so I'll just check that you can hear on that too. So somebody's going to say testing, testing, even though she doesn't want to.
Testing?
Yes, I can hear testing.
Great. Thank you. So any questions for Alison from the room? Yep, there's one up. Okay, couple up that way.
Hello there. What if you didn't get diagnosed with spinal fractures until about 5 years later when you developed back pain? How does all these treatments work then, or do they, or is it okay now that I'm taking some rising rate and about to start injections this weekend, I think it is. Does it make any difference, or can it improve matters? Or am I stuck with it because it is apparently I've been diagnosed as having it severe?
Right.
Just a bit concerned about all that just now.
Yeah, no, treatment works, whatever point you instigated. So it's a pity that it wasn't picked up right from the very beginning, from the time you had perhaps the first fracture, because then they might be able to prevent you having any other fractures. But it still will prevent further fractures from where you are now. So treatment does work. And are the injections, are these ones you're going to be taking every day?
Tetraparadite, I think it is.
Yeah, absolutely. So teriparatide is a very well established treatment that's a bone building therapy, and it's been licensed since about 2005 and should cause significant improvements in your bone thickness and should reduce the chance of you having a further spinal fracture by around 90%. I presume you're going to stop your Resedronate though as you start the fractures, because you shouldn't take the two together.
Apparently so, but I took it last Monday and they're just trying to find out whether I can actually get the new treatment on Saturday, tomorrow. So yes, I don't know yet.
Yes, no, that will be fine, but you don't take the two treatments together.
No, I realise that. Now I went to the doctor about when I fell. My daughter left water in the bathroom and I fell about 5 years ago or more, and I told them about this and they didn't do anything at all for me.
Yeah.
Even though I said I had a family history, had early menopause, I was getting round-shouldered and I'd lost height. And one main important thing I think should add to the criteria is they say 2 years, 2 inches, it's not 2 inches, you can lose 1 inch and still have osteoporosis.
Oh no, absolutely. And I think the problem, and I guess that's why this Lydia project and things like this are so important. It's getting that message out to primary care physicians, and I would say that in the 1990s, and I've been practicing medicine since the late 1980s, there was a big program out to minimize the use of radiation in individuals, and we were told that we shouldn't order spinal x-rays unless absolutely essential. And I think the problem is that message is stuck, so that GPs don't like to do too many spinal x-rays, but they're the only way of diagnosing a vertebral fracture is by having a spinal x-ray. And we have to get the message over that under certain circumstances you should be doing spinal x-rays, particularly in someone presenting with other risk factors. Back pain is common, but with other risk factors for osteoporosis, we need to make awareness of that within primary care, so that x-rays are organised, the fracture is picked up, and then the services then move on from there more promptly than they do at the moment. So I think
my daughter's an OT and she went through the criteria with me some years ago and I fell into the category, but they didn't do anything for me whatsoever.
I know.
Also, can I just mention before I finish that at the hospital they say there's not enough practitioners to help with the DEXA scanning, hence the delay.
Yes, no, absolutely, and that's a huge problem. And I say, and it partly is because we don't. Osteoporosis scans don't have any waiting time guarantees. The government set waiting time guarantees for certain things, such as cancer services, etc., and how long you can wait for a new patient appointment in clinics, for example. And they have waiting time guarantees for MRI scans and for CT scans, but they don't have them for osteoporosis scans. And that means there's no priority given. And COVID has made this so much worse because things were just closed and the waiting times are just dreadful at the moment. They are picking up, they are improving. Our own waiting times are now 5 months for a routine scan, but urgent scans for someone, for example, who's had a vertebral fracture, we'd be able to scan you within 2 to 3 weeks. But that's not throughout the country. That does vary. So I hope you do well with your new treatment.
I believe your predecessor, Dr. Reid, set up mobile DEXA scans around the Highlands and Islands. Is that still ongoing, or do you have more less portable ones around?
Yes, no, we do have a mobile DEXA scanner still. It was set up in 2014, and it still goes to Shetland and Orkney and to rural Aberdeenshire. It actually goes to Royal Deeside, that sort of area. We would like to be able to expand it to go elsewhere, but we'd need more staff to do so. But it certainly works very well for the islands, for Shetland and Orkney. In Grampian, we have a standalone scanner at Dr Gray's Hospital in Elgin, which is obviously up at the top of Grampian, and we have two standalone scanners in Aberdeen, and then our mobile scanner as well. So we're very fortunate in Grampian. We're very well served by DEXA scanners. Like everywhere else, our problem is more we don't have enough radiographer hours to keep our waiting times really low as we would like them to be.
Oh, somebody first.
I just wanted to ask about dentition and precluding treatment for osteoporosis.
Okay, so I think you're talking about osteonecrosis of the jaw, which is a very rare side effect that can occur in people who've been taking bisphosphonates for a long period of time. The risks are really very, very small indeed. It's estimated it's about 1 in 1,000 individuals who've been on bisphosphonates for longer than 5 years might have an issue with osteoporosis medications such as bisphosphonates. It's somewhere between 1 in 1,000 and 1 in 100,000. The exact incidence isn't known. It is commoner in people who have bad circulation, peripheral vascular disease. It's commoner in people who are on steroid medications, and it's commoner in people who have very poor dentition. It tends to only occur when you have a tooth taken out or have a dental implant. And the most important thing is, if you're on these medications, is that your dentist is aware that you're on such medications and you see your dentist regularly. It doesn't stop you having a tooth out, and it doesn't stop you having an implant. It should just be done with the knowledge of the dentist that you are on these medications. The risk of fracture, having a significant fracture, way outweighs any risks of these medications.
Yes, I was just wondering, years ago when I still lived and worked in America, we would occasionally do community health fairs. And we would do like bone density scans with the little machine that read it around the ankles, bones and things like that. How useful are things like that as predictors to lead into to say to your GP that it might need to be taken further?
Yeah, well, there's a couple of different ways of doing a peripheral scan. The first one, and the ones that most commonly would seen around health fairs, etc., are ultrasound scans of the heel bone. And studies of ultrasound of the heel showed that they could predict the risk of hip fracture in the very elderly. So those aged 75 years plus, but they didn't show much in the way of fracture prediction in younger individuals. You can also do a peripheral DEXA scanner of the heel. It's called a PIXI scanner, and that it could be more predictive in those over the age of 75 of other fractures as well. But these techniques are not actually any better than simply doing a FRAC score, which is a lot cheaper to do. And you can do your own FRAC score and take it to your GP and say, actually, I did this, and it said that my risk of fracture was 19% over the next 10 years. Do you think something should be done about this? And the answer, of course, is yes, something should be done about that. You should be referred for an osteoporosis scan if that were the case.
Thank you. Any other? Oh, there's another question.
I wondered if you could just tell me, please, what the current thinking is of taking medications for osteoporosis long term. I don't want to go into personal details, but I was told to come off because I'd been on them for so long. Is there any thinking on that at the moment?
Yeah, so I think when we're treating osteoporosis is a chronic condition. Once a diagnosis has been made, in most people, you will continue to have osteoporosis, i.e. thin bones, but your fracture risks are decreased by the medications. Okay, so things like bisphosphonates are really long-acting medications. So if you've had 5 years of a bisphosphonate, its therapeutic benefits will continue to be working even when you're not taking the treatment. And the reason we now have gaps in therapy are to minimise any long-term risks of treatment. So it's pretty normal to take treatment for 5 years, have a few years gap, and perhaps have another course of treatment, so that treatment occurs over a lifetime with gaps. And during those gaps, your risk of fracture doesn't increase, but the risk of side effects goes down, and then you're able to intervene with other treatment going forward. There are some individuals who are at very high risk of fracture, potentially people who've got very low bone mass and perhaps are taking steroid therapies, or perhaps with multiple vertebral fractures. And in them, sometimes we don't have treatment holidays, but for the majority of people, we'll have little gaps in treatment. And you can be reassured that if you've had treatment for a number of years, that treatment continues to have its effect for a long time to come. Bisphosphonates bind into your bone and are probably in your skeleton for decades to come.
Thank you. I think we've just got time now for one more question. Thanks.
Hiya, I'm a current paramedic student. I was just wondering, you've been speaking quite a lot about education in primary healthcare. Is there anything that you can see as an important role in pre-hospital care? Because obviously paramedics go to a lot of force patients, older patients. I know you mentioned like the FRAX tools. Is there anything else you would give as advice to paramedics in pre-hospital environment?
Yeah, no, I agree. I think we should all take every opportunity to speak about osteoporosis. This is what I do for a living, and I give talks to women's groups, the Women's Guild, and I will speak to any group that invite me to come and talk about osteoporosis and getting the message out there, because osteoporosis, as you know, is a silent condition until you start breaking bones, which is why it's really important to be aware of risk factors for osteoporosis. In Grampian, we have what's called a conversation, a patient conversation that can be had with anyone, and this is done by our health point. So if patients or individuals go along to a health point for something else, they can have a conversation about osteoporosis, and it's led by non-healthcare professionals, and it's just questions about risk factors. When was your menopause? Was it below the age of 45? Oh, have you thought about osteoporosis? And oh, you've broken a bone. Have you thought about osteoporosis? And going through these scenarios. So these sorts of conversations are really useful to have by anyone who interacts with people at all, be they lay people, be they other healthcare professionals. Getting the message out that of what this silent condition can mean is extremely important. And we're much better about getting our blood pressure checked, aren't we? We don't think that our blood pressure doesn't give us any symptoms either, but your GP will check your blood pressure for all sorts of reasons, because we know that blood pressure predisposes to heart attacks or strokes. The risk of having thin bones to fractures is a much higher association than blood pressure to stroke. So we really should be having these conversations far more regularly.
Thank you. Actually, Alison, do you have time for just one very quick, short question, if that's okay?
Yep.
Yep, thanks.
Yes, okay. My question is, apart from treatment to slow or stop the loss of bone density to osteoporosis, is there any cure or total eradication for osteoporosis condition?
Yes, no, I'm afraid is the short answer. I think having how thick or thin your bones are is due to your whole life events. It's due to how thick your bones got to when you were in your teenage years. So we want good lifestyle. We want children not smoking. We want children taking lots of weight-bearing exercise and having good diets. We want the recognition of good health during a young adult life. Again, no smoking, not excess alcohol, good weight-bearing exercise. And that would reduce the burden of osteoporosis. But for many people, their osteoporosis is due to medical conditions that they suffer or due to genetic factors. And although we can reduce the risk of fracture with medications, and they do reduce the risk of fracture really very significantly, we haven't got anything that takes your bones back to where we would like them all to be. But perhaps one day.
Thank you very much. Can we just say thank you to Alison? Thank you. And thank you for just on the hoof, you know, doing the team's presentation with us, because I know that you'd recorded a presentation, but at the last minute we weren't able to use that. So thanks again, Alison. That was great. Thank you.
No worries. I hope you all go home safely. I don't know what the weather's like with you, but it's pretty awful here.
A bit better down here, I think. But yeah, take care. Thank you.
Thank you.